Hello, friends. Welcome back to Missed Conversations with Rahat Beri. Today, we are joined by a man who has held not just lives but courage in his hands. Senior oncologist Dr. Rusi Bhalla, who has more than 40 years of medical experience, thousands of laser onco surgeries, and a lifetime rewired by what he has seen. For people who are not familiar, laser oncosurgery is a new perspective in treating cancer, and it's a non invasive approach. So, welcome, doctor. Thank you.
Thank you for having me, Rahat.
Okay, we'll start from the very beginning, doctor. What sparked your fascination to, of course, you've done the medical degree, but towards cancer and then looking at the laser as a surgical tool?
I think in every doctor's life, there comes a time when, there is some anecdotal case which happens, which sparks off an interest. And it was not different, very different in mine, because we were already doing laser for small works like proctology and everything we were already doing. And then one fine day, one patient was referred to me. It was a case of recurrent buccal carcinoma, oral carcinoma, and he had a lot of metastasis in this. And the referring doctor said, "Doctor, you do something, you'll do something," he was really in a bad. So I said, "Okay, let's try this," because because we knew we can burn off that tumor. And then when we did that, um, we were surprised ourselves, because it was a journey on which every step is a surprise, because we've been used to cancer surgeries and all the problems, and
It's the most common
it's very
process.
common. It's very common. And the next day, the patient said, "Doc, thanks a lot." I said, "Why?" He said, "My pain is gone." And we were surprised, because this is something which is now routine with us. But that time it was a very big thing for us, that the pain went away. We put him on a little bit of chemotherapy, and within 8 months there was no sign of cancer in that area.
Wow.
And this was the early years, 10 years back. Then we realized we were on to something, because probably at that time we were doing about maybe 3-4 cases every 6 months or something.
Okay.
So then one thing led to another, and then we had to research. So we had to research a lot, and luckily, because of the internet, we could do that. So when we researched, and this is the funny part, that we had to research, because normally you research why you are failing.
So you turned it around.
So we had to research why we are succeeding.
Okay, very interesting.
You
Very
understand?
interesting.
So
yeah.
we had to research why we are succeeding. And then we found out that we had to actually go into the subtle nuances of surgery, then chemotherapy, radiotherapy, everything. So then we had to go into, as the stories went on, the cases went on, we did a lot of research into the side effects of the conventional treatment. It was easy for us, because we have been through Tata Hospital and everything.
Sure.
So, and we are surgeons ourselves. So we could understand the problems in a much better way than, let's say, an oncologist or a radiologist or somebody who.
So internationally, you're saying laser is not used so much, so you didn't have those studies to look at?
Right now, we were looking into studies which are isolated studies, which are coming out from
Okay.
parts of the world. That was long time back. But even then, all the studies were very encouraging on laser.
Okay.
Because laser is your new tool for surgery, and it is not just applicable in oncosurgery. It is applicable in so many
Yeah.
fields. I mean, laser is like, for example, we were doing cataract operations.
Yeah.
2 months recovery, black. Now, if you do it with laser, so it's a 15-minute
yeah.
recovery. 30 minutes, he's driving a car back home.
Yeah.
You
It's the
understand?
same
So
day.
it's actually the same thing. I mean, it's just that there are different lasers. You need to have a
The
different
onco laser
study.
would be a different.
It would be a different laser. It would be a different study altogether. But then we went through a lot of soul searching, I would say.
Okay.
We went to a lot of soul searching, and you had to accept the fact that things are not right in what we are doing for the patients, because the results are not right. And we always tell people that if the result is not satisfactory, that means your procedure itself could
This-
not be satisfactory.
Sure.
And if your procedure is satisfactory, then the results
Will show
where
itself.
it just shows. And not it is one follows the other.
True. True.
So that's how it all started.
So when you first began working with laser, as you said, it's basically an awakening for you also with the whole process. So you must have faced a lot of skepticism.
Oh yes, we had a lot of skepticism because I think it's warranted in a field like medicine to openly accept something which is new. Frankly, I don't think even I would do it.
Okay.
I mean, I would not do it. But then the results speak for themselves. So if the results are coming up in the way which are much better than your conventional thing, then you have to look at them seriously, and then you have to look at them with a open mind.
Okay.
And possibly my mind was open.
At that point of time. Okay. All right. Doctor, what are earlier signs? Like we say when you do a laser, I'm sure there are do's and don'ts, right? Not every treatment can be treated by laser.
Really?
And what are the earlier signs for people to understand that there is a possibility to avoid surgery and use a laser?
See, I specialize in two surgeries. I mean, one is oral and one is breast cancer.
Sure.
So I feel that because we have done everything from stage 1 to stage 4. So we feel that right now with the results which have come in, we've been doing it for a very, very long time. We feel that if somebody does not want surgery and it has been recommended to him, he need not do it. You have an extremely good viable alternative in laser.
Okay.
You have to understand ultimately what is oncosurgery. Oncosurgery is taking out a tumor. You understand? Most of the patients don't understand that there's a difference between tumor and cancer.
Okay.
Tumor is a part of cancer.
True. True.
It may be 95% of the whole disease. Together we call it a disease.
Okay.
So cancer is something which is spread around in that area. So what we see is a tumor.
So tumor is a part of it.
Tumor is a part of cancer.
Okay.
And therefore, that is the first step which we have to realize is that the procedure what we do like surgery is not a complete procedure, which is never. I don't see even when we were in Tata, we were explaining that part to the patients. So patients are of the opinion that if they take out the tumor, they've taken out the cancer.
The problem is solved.
The problem is not solved. And that is the reason why, alternative or your adjunct treatments like chemotherapy and radiotherapy are given. If 100% of the cancer was coming out of surgery, then why would you need chemotherapy or radiotherapy?
Yeah.
And
And a
these
lot
by
of-
themselves have a lot of side effects.
A lot of them also happen is that your problem is solved, but you'll end up spreading it to other areas.
Yeah. That's the hidden part of oncosurgery.
Yeah.
And if you actually look it up on the internet, and that's having said that, this was never taught to us in when we were doing surgeries, that surgery itself can spread the cancer. And luckily now there is a lot more awareness of the fact, and there are a lot of studies which have come up recently, and anybody can look them in the internet by
And,
just googling something like surgery spreading cancer. So you get a lot
get
of
that
studies.
information.
You get that information. In fact, the major hospital in India has already acknowledged the fact that during breast cancer surgeries, there is a good chance that the surgery is spreading the cancer.
Wow.
And they have done some small studies on how to stop the spread, which have been probably successful by another 4 to 5%. Significant or insignificant, but yes.
Okay.
But the
at
point
least
is,
there's a beginning.
Yeah, there's a
There's a
beginning.
beginning.
They've realized that the knife itself can spread the cancer,
Interesting.
and there are particular reasons for that. And something like tumor handling is one of the most common ones. Then your immune status gets altered. There is a lot of circulating tumor cells which get deposited. So all these studies are coming up now.
Okay. So, Doc, when you have a detection, when you're told earlier, what are the kind of tests you should taken once you come to know, or are there tests you can also take in to figure out, see, you don't do a PET scan all the time, but how do you get to know? Because a lot of times people get to know about it
See, when I'm talking about, I'm
later.
talking about, again, oral and breast cancer. We are not really, because there's a huge gamut of
Sure.
cancers. We cannot go individually into in this. But the platinum standard, or the accepted mode right now for oral cancer is MRI.
Okay.
And we can just do a plain MRI without any, it gives you all the information what you need. Because oral cancer has a particular speciality, is that it spreads to the other parts of the body very late.
Okay.
So you can get away with just an MRI scan. I mean,
Okay.
most of the times when you're doing a PET scan, there will hardly be anything
Showing
outside
on
the neck or the oral cavity. But it's not the same thing with breast cancer. Now, breast cancer, I think the PET scan has been a real revolutionary investigation for breast cancer, because all the information which you need for the breast cancer to treat it is now available with sonography, sonomammography, and a PET scan combination.
Okay.
So PET scan will tell us not only the problematic tumor, it will also tell us how much, whether it is actually spread to the lymph nodes.
Okay.
Initially, what we were doing was that we were actually dissecting the lymph nodes
Okay.
and then putting them under microscope and seeing whether there is something there or not.
Okay.
But now with the PET scan, it's very easy. You can always, for a fact that it is already spread or not spread.
Okay.
away.
So the
So the
identification
staging is much better now.
in the PET scan.
So you can do the staging of the cancer, of breast cancer, prior to even putting your patient on table.
Okay.
So that is a huge, because
That's
all the
interesting.
prognosis and everything depends on the staging
Okay.
of every cancer. I mean, oral or
Okay,
breast
you've
cancer.
done so many cases, doctor. Any interesting cases which you could walk us through? Maybe the one which is the most transformative one and has kept you.
Oh, there are many. So, but a lot of times I always, when I take lectures for doctors or other people, so I always say that the side effect of laser is overconfidence,
Okay.
because you get by in sometimes absolutely inoperable cases with with nobody even knowing around you that something was done. So because it's totally there's just no cut anywhere. And one of the cases which comes to my mind, which I always say, and I have these photographs to prove it, is that there was one patient who had very bad tongue cancer, and he was given hardly less than a month to live, and there was nobody who was going to operate on him, and somehow he came to me, via some friends or relatives, and we did a laser for him, and he responded extremely well, because it also depends on if your cancer cells are very receptive to chemotherapy, you can really get by, because see, with laser what we do is that we can just take out 95% of the cancer tumor load.
So you burn
without
it,
a problem.
right?
We just burn
You
it.
burn
we
it,
just
right.
burn it. So actually, it's not that easy, but yes, we burn it. So it takes 10 years of experience to burn it.
Sure.
So, but he responded very well. In fact, he recovered totally. After 6 months, there was nothing on MRI, PET scan negative, everything.
Totally. With
Totally,
saying that.
totally.
Wow.
And he came to me after 3 years, and he was 20 kgs plus. So we couldn't even recognize him. And actually, because we document every case. So we had the previous pictures and we had the now pictures. And we can share those pictures with you also. And he was fantastic. And I kept looking at him, and he kept looking at me. I said, let me take in this moment, because this was earlier in our career,
Okay.
And when
It just
hopeless
keeps on
cases,
motivating
it
you,
just keeps
right?
on motivating you. Look, if these guys can come out, maybe the other one can come out, that sort of thing. So after 4 years, when he came, his wife told that, doctor, please tell him he's drinking a lot. So I told him that you can't drink, this is whatever it may be. He said, no, I don't drink. I'm just either whatever. And
He's
was
just
a farmer.
happy.
He was so happy in life, because from 15 days stay to
Being totally cured.
totally cured. It's a totally different ball game.
Different, yeah.
He died of liver cirrhosis after
God.
4 years. And there are many such cases where they went overboard because when they were given just 15, 20 days to live, I've got a patient who was okay at 6 years, and his report when he sent it to America, they said nothing can be done, and he was well connected with some guys, some oncologists in US. And then after 6 years he's cancer free, and then he takes up to alcohol and nicotine and everything. So my point is that that is the side effect of laser. People get overconfident
Wow.
that this is nothing.
If I
My
can
doctors
overcome
are,
this, I can do
I can,
anything.
yeah, I can. I'm a Superman. That's the whole problem.
Okay. Your research shows laser ablation as a viable alternative to mastectomy for certain breast cancer patients. Can you walk us through how it
See,
works?
laser ablation. See, ablation is basically burning of tissues. So you
Okay.
can do it in 4 ways.
Okay.
You can do it with microwave ablation. You
Okay.
can do it with radio frequency ablation. You can do cryoablation. That means you can freeze that whole tumor.
Okay.
A lot of work in that thing is being done in Israel. And laser.
Okay.
You can, obviously, every ablation technique is not available everywhere. But laser, by and large, it's a much better way to ablate the tumor, and you can have a very control on
Okay.
the amount and the area which you can burn out.
Okay.
And it's done in real time under sonography, so you know
Okay.
exactly where you are.
Where you're going, yeah.
And this is the I would say the next frontier in medicine is laser. And you're hearing about laser everywhere. It's
Yeah,
not
that's
just
true, that's true.
I'm not the first person talking about laser. You can do it
No,
in
you do
urology.
it. I've had a doctor. We
Yeah.
did the whole endometriosis, where
Exactly.
again,
So
everything is done laser,
Yeah.
and now it's become robotic also.
Yeah.
Things are happening through the robot. So
Why-
yeah,
what
I
we
think
were
we're
taught,
moving.
we were taught in I think MS. I'm not practicing it any longer.
So you're constantly
So
learning
we're
and
constantly
upgrading
learning and
yourself.
upgrading yourselves.
True.
And I think the earliest one which we saw reports were coming out from US.
Okay.
There was a company which was doing for very early breast cancers, and they were reporting very fantastic results.
Okay.
And they are the people who actually got the US FDA to look at it seriously. And now, to the best of my knowledge, is US FDA approved.
Oh wow, that's nice. That's
laser
good to
ablation,
know.
Laser ablation of early breast cancers.
Okay. So you have a US FDA, you have in Europe, so I think it's okay. So I think that comes to the next question. I'm sure it'll be close to what you're saying. Where do you see the future of surgical oncology changing over the next decade?
I think I can sum it up in one sentence. I do that in all my lectures, and some people like it, some people don't. But that's the nature of the game. Is that I feel that the future of surgery is no surgery, whether you like it or you don't like it. And we're seeing it all around us.
Okay.
From the big operations of cardiovascular thoracic surgery, they're all gone down to angioplasty, which is again an example of no surgery.
True.
When we were residents, we were doing a lot of work on the biliary tract, and that was a very morbid procedure. I mean, to touch somebody's biliary tract and expect him to recover within 24 hours was not possible. 24 days was something what we used to look at.
Okay.
And right now we are having a 24 hours recovery.
Wow.
With the ERCP, endoscopic retrograde cholangiopancreatography, and all those things. And I think most of the gastro part has already gone to as an example of no surgery.
Okay.
We are doing so much of these procedures,
Okay.
which were very big procedures now.
Okay.
ENT is another example. So the future of surgery, as you call, is no surgery. If there's a better word for it, I'll probably use it next time. But today, I look at it as no surgery.
Okay. So what are the main limitations or risks associated with laser ablation in cancer?
See, it's a learning curve.
Okay.
You understand? Because when you are working with laser, you have to understand laser is only 30 to 40% of the work.
Okay.
The rest is we had to rework the whole of oncology.
Okay.
For example, we had to steel ourselves not to use radiotherapy.
Okay.
We don't do radiotherapy. And radiotherapy we don't do because radiotherapy is a high causative factor for secondary
Yeah,
cancers.
that's what I was
Secondary
just going to say.
cancers.
Yeah.
So, and you really don't require it. I mean, our study, what we have seen is that your best results are coming out without radiotherapy. In fact, we do a lot of recurrence cases.
Okay.
And what we are seeing is that if you ever taken radiotherapy, those patients are practically impossible to get out.
Get out of.
You can't cure them. And we have had patients who were okay for 2 years and suddenly, the cancer spread in the oral area. And we've got patients of
But
breast
what is
cancer.
the cause for that?
The radiotherapy causes the genetic changes in the
Okay.
surrounding cells, which are normal.
Okay.
So this is a known fact. This is
Okay.
all over the internet. I mean, it's a very known fact.
Sure.
That's the reason you're afraid of radiation at the end of the day.
Absolutely.
You understand? The problem is the same whether you give it medically or you give it accidentally via nuclear blast and you survive it. So
So
cancer would be, But having said that, it's a very controversial topic. So in oral and breast, we don't see any reason for it right now.
So how expensive are these surgeries? And you think a common person can afford these?
Oh, definitely. I mean, we are not talking now government hospitals, but in a private setup, most of the cost, I think it's about 30 to 40% of what they would probably spend in a private hospital.
Okay. So somebody with no insurance or something can
Oh
still
yes,
go
definitely.
through it.
Yeah, of course. 100%.
Okay. All right. So in your published work, you followed patients for years post laser ablation. What long-term data gives you confidence in this approach, and where does more research need to happen?
I think if I had the wherewithal, I would do more research on other cancers, because the principles remain the same. Principles of laser surgery is that you decrease the tumor load
Okay.
by a considerable margin. I mean, we are
Alright.
talking 95% up.
Wow.
So now after that, if you're left with just 2% of the cancer, then the chemotherapy can take over in a much better way.
Okay.
And
So the balance is
yeah,
important.
so that's one of the reasons why our results are much better. And then we don't give radiation, so there's no. If you are cured, you're cured.
Yeah.
You understand?
I
It
think the
doesn't really
biggest
come
fear
back.
people have with
Yeah.
cancer is the radiation part of
No,
it.
see what has happened is that the results of cancer surgery overall have not are basically stage dependent.
Okay.
So if it's stage 1, obviously you will have a better prognosis. You
Sure.
will have a stage 4, you will not have and those results have not really changed in the last 50 years we have been doing
Okay.
oncology as a separate field. But
Is it only in
now
India
we are
or
seeing-
is it globally?
It's globally. It's globally. It's globally. Maybe 5% here, 10%. But wherever you realize that because the results, unless and until you are actually categorizing them by stage wise, they're always said, okay, we have got an 80% survival rate. Yes, 80% survival rate would be more towards, stage 1.
Okay.
But if you take stage 4, there would be,
Lesser
a high
chances.
5%. So if you take a comparison, then you say, okay, 60-70%. That's fine. But if you take it stage wise, I think more or less the results are same all over the world.
Okay. So for a young surgeon today who wants to learn laser oncology, what does the training pipeline look like, and what advice would you give them?
I would always say that start with non-oncology first. Okay. And, proctology is one of the best ways you can do it. But you have to keep an open mind. That I always tell people that laser surgery is not surgery with laser.
True, that's a misconception, yeah.
So I've seen a lot of young guys and other surgeons trying to do the same surgery with laser.
Okay.
So that means now they're using laser as a cutting tool.
Okay.
So you get the same results. You understand? So you have to look at laser as an ablative tool.
Okay.
And then you have to control the ablation. So that's a learning curve, which these people have to go through. And unfortunately, there are not many books. I'm writing a book, so maybe
Well, that's
one or
lovely.
2 years it'll come back. It'll be help to the younger.
I think there is
surgeons.
somebody from Tata Memorial is also writing a book with regards to surgery and laser, and non, surgery, success of surgeries. I've just come to know about it, and he's actually questioning. So it's interesting. I'm sure people are now putting together their experiences
Yeah,
into
and
paper. I think it's very, very important.
laser papers are coming up all over the world now.
Okay.
And I see a lot of them now, getting the focus on laser, because that's the best way. See, even if you are working with something like genetic drugs, you are, gene transforming
Therapies,
drugs or whatever, maybe monoclonal antibodies and things like that. The primary thing what you need is a reduction in the tumor load.
Okay.
You understand my point? So if you can do that without surgery, then the rest of the treatments can also start working.
Yeah, true. But this messes you up so badly when you do the surgery
Exactly.
that the rest of them just
Yeah.
pile on upon you.
Because the side effects of surgery are so bad
Yeah.
that most of the patients are in total depression. And see, what we are looking at patient as an entity.
Sure.
We are not looking patient as an individual. As an individual, if you have your half of your face cut up, how much? How much willpower you have to go through life, and there are psychiatry departments in cancer hospitals. You understand my
Yeah,
point?
I know. The mental challenge.
Mental health. Why? Because what as surgeons, surgery has been performed gives you extreme amount of depression. Either as oral
And
cancer
without even
or
assuring success of it.
Without
So
even
you're
assuring
going
success.
through the whole thing.
I always tell people that yes, your surgery is not a bad thing. I have no problems with surgery. I'm a surgeon myself. I will love to do that, take up a knife and start operating again. But I have to justify a cure. If I'm going to take somebody's half face off, then I should be very confident that it is going to come to a cure. If it is not coming to a cure, then my next point is that I should be able to give him a remission. Remission means remission in a way which is acceptable to him.
True.
We can't use our own parameters. You understand?
To decide what is right and
what
wrong.
is right for you and what is wrong for
Yeah,
you.
that's true. That's
So
true.
if the patient is saying no, this is not what I bargained for, then we have to listen to him. In fact, a lot of people talk to me about what is called evidence-based medicine, because evidence-based medicine is to most of the doctors. Whenever I have a conversation with them, is something like papers or research papers or papers coming out from reputed institutions. No, that is not the whole evidence-based medicine. Evidence-based medicine is in 3 levels. One is your papers, or obviously there are 5 levels of papers. We don't have to go into that. But the patient preferences and the clinical experience of the treating doctor also is one third of evidence-based medicine. So if the patient says, okay, look, okay, you may be right, but I do not want this procedure done on myself, that's part of evidence-based medicine. If the clinician says, okay, I feel your results, you have said that you have got an 80% 5-year survival rate or something, but in my experience, these patients are not surviving 5 years, that is also evidence-based medicine.
Yeah. But that goes with knowledge, right?
That
goes with knowledge. So how many of them do go through that knowledge to be able to...
Again, as I said, this is evidence-based medicine. Today, everything is evidence-based medicine.
True.
But evidence-based medicine is not just papers.
Yeah.
It's just not research papers. It is also what you may, because there's something called an operator bias.
Okay.
If I write a paper, I'm biased towards laser.
True.
You understand?
True.
If the other person has done the same procedure under the same circumstances, he's not getting the results, then he has a right to say maybe the results don't work. And that is one of the reasons why we have been quite successful in this field, because we document every case.
True.
Every case is documented. So before and after, and maybe after 6 months or 2 years or whatever it may be. So there are so many cases which have been put on YouTube. There's so many cases we don't put, because for us it's now a normal thing.
Normal process.
Normal process. So we do document all the cases.
Okay.
And that helps us in 2 ways. We know when we have not succeeded. It's like cancer is not something where you can have 100% track record with something, because as I said, the staging is very important. And we are fairly successful because we have been able to retrospectively go back and see what went wrong.
Okay.
we were always better than the results are always better than the conventional treatment. But to get from somebody who's going to be around for 6 months to 1 year, then you take it to 1.5 year, then at 2 years he's MRI negative, because we don't say just on a subjective basis. Whenever we come in the picture, or our center comes in the picture, it's an objective diagnosis.
Okay.
So it should be demonstrable on your scan reports. It should be demonstrable
It
on
should be
your
like a proof of
clinically.
concept
It's
kind
a
of.
proof of concept.
True.
That's very true. So
Okay, two things that come to me is cancer. It is something which the word cancer is, when you hear it, there is a fear. Now, there are a lot of reasons people to get cancer. Is it only genetic, or is it stress? Is it all? How does it work?
I think it's an amalgamation of all.
Okay.
So there are, there are some cases which we can't, just explain other than stress. But genetic, yes, definitely genetic has, especially in breast cancer with the BRCA gene thing. So there's a lot of substance abuse. If you're talking about pancreatic cancer or stomach cancers, I think most of the patients would have a substance abuse issue.
Okay.
And if we can look at, but so many times it's just bad luck.
It's just
So you can put it to genetic. Obviously, everything is genetic.
yeah.
But genetic or bad luck, it goes together.
So I would come to the next part of it is lifestyle habits. You think certain things one should change?
I think holistic approach is one of the best things. So you should not exceed anything.
Okay.
Like, I mean, the best part I tell people is that because a lot of people think no, tobacco should not be taken or whatever. So a lot of people ask me for my comments on that. I said too much of anything is bad
Okay.
because these are recreational drugs.
Okay.
Let's look at something like Pepsi or Thumbs Up or whatever, Coca-Cola.
Yeah.
So if you take one drink in a week
Once
or
in a
two,
while, it's okay.
it's okay,
Yeah.
no problem. There's no
Okay.
issues. But if you're going to take 6 Pepsis in one day for years,
You're gonna have
I'm
an
sure there's
impact.
going to be some issue somewhere.
True.
Even you take milk is a very healthy thing, but if you start taking 3 liters of milk every day, things are going to get
So I
ugly
think
for
a
you.
little shift in your lifestyle habits are
so
important.
you should have a balanced diet and balanced lifestyle. I mean, you should be
Sure.
able to exercise. You should be able to sedentary lifestyle, which because of internet and everything, I think we have got a lot of young guys who are onto very sedentary lifestyle. That I mean, you have to compartmentalize your life now.
I
because-
think, that's what you spoke about last
Yeah.
time. I think
Because if you
compartmentalize
you have to
helps
say,
you.
mornings I'm going to spend here, afternoons I'm going to spend here, evenings I'm going to spend like this, and I'm going to eat this. Because one of the best things I tell people is that when you go to a restaurant, decide what you're going to eat, and don't get carried away. If you feel that, for example, in cancer, we have a thing with sweet things, sugar and because there's a technical reason why the cancer will flare up on that.
It spikes up,
Yeah.
right?
So
Okay.
we always tell people that if you can't, bear to see it, don't see it. Run away from there. So you have to again, it comes to compartmentalizing
Yeah.
your lifestyle.
True.
So
No, I agree.
because now with the kind of foodstuffs available on the market, you don't know what is where.
Yeah.
I mean, I personally avoid all packaged food.
Yeah. I was just going to say that.
I
next,
just
yeah.
really avoid packaged food, and the more I look on the internet, the more I'm convinced that it was the right decision. It's not that we have all the answers. Sometimes I think the internet
But I
has
think
more
there
answers.
are certain things you need to
Yeah.
discipline yourself
Yeah,
with
absolutely.
to be able to. Okay, Doc, with so many cases, I'm sure, can you tell me some of the most challenging ones for you? I know you've told us something interesting, but what have been the most challenging one for you?
I think, see, when we look at, again, like I said, oral and breast cancer only. So, when we look at these two cancers, we divide it into stage 4 because the earlier ones are not really a problem. And the challenging comes in two parts. One is it an operable cancer or it's a non-operable cancer? When you talk about non-operable is that the patient goes to the hospital and says, the doctor says, sorry, I can't operate on, I'll give you some chemotherapy, I'll give you some radiotherapy, and that things
Just
like
to
that,
keep you going.
just to keep you going. So we have done a significant amount of cases. Like in breast cancer, we did a lady who had you have to understand now what a 10 centimeter tumor means. 10 centimeter is something like a tennis
Like a
ball.
ball. I was
Is
just gonna
occupying
say.
most of the breast,
Wow.
and she's still alive with us at about 4 years. So that was a challenging part too, because it took us almost 3 years to ablate 3 hours, even to ablate that whole tumor. And when we did her PET scan after 3 years, that area is negative for
Totally.
cancer.
Wow.
I
It's a
mean,
lot of satisfying experience, no?
I'm sure it is. I'm sure it is, and it just makes you wonder, okay, what we were doing. What were we doing? What were we thinking when we were operating this case? And in oral cancer, there's a lot of cases where we get a lot of recurrence cases.
Okay.
And because when we always tell people is that in surgery we have a plan A, there's no plan B. So the plan B becomes the laser,
Okay.
because you don't want to do a surgery again, things like that. So if there are so many cases who did not have radiotherapy, and now we were successfully able to ablate and then manage them, and today 2 years, 3 years they're cancer free. But we were able to give a lot of people uh, a good life for for a
Some level.
considerable
You're
period of
basically
time.
giving hope to people,
Yeah.
right? You're
So, for
giving
example,
hope.
we had one case from Hyderabad who was a case of parotid gland, which was quite enlarged, and Hyderabad best doctors told him nothing can be done. And uh, after 6 months, when he went back for the PET scan, there was nothing there. But he got some recurrence or something. But we, instead of him expiring at maybe having a limited lifespan of about a month or two, we were able to give him 3 years. That itself, I mean,
It's a lot
it's a
for
lot for
somebody.
somebody. For us, when we are practicing, we don't notice the 3 years gone by. But for to him to even comfortable 3 years, this was not something which was uncomfortable.
In
So
pain or
yeah, in
anything.
pain or anything, it was very comfortable. 2.5, 3 years we had to give him.
So many patients are afraid of cutting surgery. So how do you counsel someone who's apprehensive but eligible for laser ablation?
Um, See, I think most of the patients who have already decided they don't want cutting surgery are in. Uh, I put them in a different category, or maybe two categories, where either they have looked up the side effects of cutting something,
Okay.
or if they're um I mean, these are the people who have gone to, let's say, Tata Hospital or all these places where they have seen patients with a a nasotracheal tube, nasogastric tube, or some here. They say, no, I don't want to live like that. So these are the patients who are. We don't have to counsel them. They are okay with. They just want the thing done tomorrow. And then there are patients who are have had relatives or something who had been operated, and obviously because the most of the results are not good, I mean to say the least. So they are also very convinced at that point in time. So not so much of counseling is required. But then the third part is that they are in two minds whether to get this surgery done or to get this laser done. So I think we don't. I mean, we try to counsel them by giving them the pros and cons of
Okay.
each and every
The realities,
treatment, the
basically.
reality. So we got a lot of photographs of patients who have been in recurrence and everything. So, and we never ever tell them, okay, look, it's not that laser is 100%, what you are going to get. But then if you are okay with this kind of risk, then, but if you do not want that,
True.
then you can be assured that laser in our uh, when you look at from my point of view, it's a better alternative in surgery.
Okay.
But then obviously there's not everybody gets convinced on that, so they go for surgery. But I have not had anybody coming and telling me after 2 months, doctor, you were wrong.
Okay. That's a good one. So, how do you think the wider healthcare system should evolve to better support minimally invasive cancer treatments?
I think it's already being done in so many levels in
Okay.
medical institutions.
Okay.
And especially because I think India has one of the most robust health care systems worldwide, I would say.
True.
You know, what you can get done in just a 1 kilometer of radius. Even in tier 2 cities, it is next to impossible to get it done in New York or
Internationally.
London
Yeah,
or
yeah. I
internationally.
agree. I totally agree.
So we've got a world-class hospitals here, and with world-class
The process
hospitals,
is so much more
it's
faster.
much more faster. And second thing is that the surgeons are already quite well trained in this minimally invasive thing. We are doing at our bit from our side that we are probably going to start another program for the younger surgeons to
Okay.
go
That's
into
nice.
laser.
That's good.
That's the final act of our of our play sometimes down the
Okay.
line.
So, what are the common myths or misunderstandings people have about laser surgery? Do you think?
I think the most common myth they have is that laser is equal to radiotherapy.
Oh,
So it's like वो भी light जैसा है क्या? Then we have to tell them no, the laser is
Okay.
basically heat. It is not radiation because they're very afraid of radiation.
okay.
Anybody who has seen a patient of radiation really does not want it.
True.
So therefore there's a word in English called euphemism.
Okay.
So when we talk about radiation, we don't talk about radiation as whatever they talk about it as light.
Light.
So it's not light. It's seriously not light.
the problem.
In fact, there is no light there.
Light at all? Yeah, I was just gonna say.
So that's one of the biggest myths of which we encounter.
Okay.
So we have to tell them laser is. We have to explain to them laser. Of course, we have got videos, we've got results and everything.
Yeah, but it's weird, no? When somebody comes to you and thinks it's a light that you're
it's a
putting
light.
inside the
It's
body.
like
or-
radiation because radiation is also called light.
Yeah,
Understand
that's
this
true.
point.
That's true.
So which is not light at the end of
Okay.
the day. So I think that's something which we have to explain.
So, if you
in
look
every
20 years
consultation.
ahead, what do you want your legacy in surgical oncology to be? And what change do you most want to leave behind?
I want to leave behind a world where people are not afraid of cancer. That there's a logical way to treat cancer, and it's there in front of us. It's not that, and the results are there because our results are all over the internet.
True.
And most of the patients who come to us, 90% of them come through the internet. We are able to give telephone numbers of patients whom you can talk to.
References.
References. We
Yeah.
maybe the only people in
That's the most
whole of
calming-
oncology
yeah,
that we can give a reference.
True.
And and I think that is something which I want most of the surgeons to get. You should have a certain training, and obviously, as a general surgeon, you need general surgeons with a general surgery training. But the sad part is that once you've done the general surgery training, you have to leave it all behind.
Yeah.
So that's the legacy. My legacy would be probably a bit anti-surgery.
But also to move ahead, no?
Yeah,
So,
we
as
need
you
to move
said,
ahead.
Doc, that you need to, of course, do the initial surgery to the young surgeons, but move ahead with it. Don't
move ahead.
stop.
Take that knowledge with
And
you
utilize
move
it.
ahead.
Yeah,
you have to
I think
utilize that
that is,
knowledge and move ahead.
That's important.
Yeah.
So, okay, I'm going to do some rapid fire questions. Do you believe laser surgery will become the standard of care for certain cancers in the next 10 years?
I think it's 5 years.
Have you ever failed at a laser procedure that made you rethink your approach?
Oh, we were doing all the time in the first 10 years because as I said, most of the laser is just 30-40% is laser. The 60% is reworking. For example, we realized there's a huge connection with the diet and laser.
True.
Which we knew but we never really realized so much of it. That we knew there is a relation between something like simple like mouth opening and oral cancer. So these things, something which we learned on the way. It's all there. The knowledge is all there on the internet, but it was like a jigsaw puzzle. So we had to put. It's not something like jigsaw puzzle. We can do it in 1 hour thing. You have to do it 1 year at a time, one piece. So that's why.
Okay.
There was a lot of.
So you don't
time
unsolve it all together.
Yeah, you can't do all of them at one point. So you have to put one jigsaw puzzle put one pace, then see the effect, and then go another 4 5 months and all.
So solving
But the
it piece
best
by
part
piece.
is, and the best, the reason we were able to, we were always far ahead in the race.
Okay.
So the ones which were behind us were far behind.
Okay.
So we had the time to, so there was nothing that we were doing anything wrong with anybody.
Okay.
Because we were always better than what the other treatment was.
So you're definitely adding value.
So we were adding value as we go along.
Okay. So please. Okay. Do you personally still perform open surgery, or is laser now your primary method?
No, I don't perform open surgery. I given up my knife 10 years back.
Would you encourage a family member diagnosed with early stage cancer to consider laser
Always.
ablation?
I would not allow a knife to be put on those patients.
Is there a cancer type today that you believe cannot be treated effectively by laser in the foreseeable future?
I think esophageal cancers would be a problem with laser.
Because you're talking the stomach.
Yeah, it's a hollow tube,
Okay.
and you do laser there, you have a problem in perforation. Liver we have already done and we have found very good result. Thyroid we have found very good result. Brain is always, there are some centers all over the world, somewhere in the world, who are doing brain with laser. So obviously they are doing well. And I would like maybe my students or people who take up to experiment with pancreas, at least with the tail of pancreas, this distal end, with laser. So
Because that
cut
is
down,
growing
yeah.
substantially.
So I feel there is a huge amount of, because it's a solid organ, and if we do it right
Okay.
and with the proper laser fundamental is to decrease the tumor load.
Okay.
So if you can decrease the tumor load and then give chemotherapy, then yes, I think that is something which I would like to see in my lifetime. That somebody took the laser fundamentals onto pancreatic cancer and then made a turnaround.
Wow. We hope so. So thank you. Thank you very much, Doctor.
Thank you, Rahat.
It was a pleasure having you here. Thank you. Dear friends, if you have enjoyed the content that we've produced, please do like, share, and subscribe.